Welcome everybody to today's session for our Neuro-Oncology Wellness Series led by the NOW team. Program Manager Rachel Garcia Fox will be moderating today. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for their continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or would like more information about the resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you for all joining us. I will now pass it over to Rachel.
Hi, everyone, and welcome to a new Neuro-Oncology Wellness Education webinar. The Neuro-Oncology Wellness, or NOW program, is a new initiative from the Center for Neuro-Oncology at the Dana-Farber Cancer Institute with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. My name is Rachel Garcia Fox. I serve as the program administrator for NOW, and I'll be your host for this series. Today, I'm joined by Dr. Nayak and Dr. Chukwueke for a discussion on central nervous system lymphoma. Dr. Nayak is the director of the Center for Central Nervous System, or CNS, lymphoma at the Dana-Farber Cancer Institute Center for Neuro-Oncology and an associate professor of neurology at Harvard Medical School. Dr. Nayak has led and is currently leading multiple clinical trials for the treatment of CNS lymphoma and other aggressive brain tumors. She's also leading an international collaboration to validate clinical scales for the assessment of patients enrolled in clinical trials. She has authored over 70 publications covering the whole range of topics in neuro-oncology and was recognized as the Dana-Farber Cancer Institute Mass General Hospital Neuro-Oncology Fellowship Teaching Award. Dr. Chukwueke is a neuro-oncologist at Dana-Farber Cancer Institute's Center for Neuro-Oncology, associate neurologist at the Brigham and Women's Hospital, and an instructor of neurology at Harvard Medical School. Dr. Chukwueke is engaged in clinical research of novel therapies in the treatment of primary and metastatic brain tumors, including central nervous system lymphoma, and is the neuro-oncology program liaison to the Center for Cancer Therapeutic Innovation at Dana-Farber. She is also interested in characterizing and addressing disparities in brain tumor care, having published multiple important studies in this area. Dr. Nayak and Dr. Chukwueke, thank you so much for joining us today.
Thank you. For this opportunity, for inviting us to speak about this disease and engage with patients. This is a tremendous opportunity for all of us, and I'm very happy that we are organizing this for all brain tumors.
So let's jump right in. We care for so many patients here with CNS lymphoma at the Center for Neuro-Oncology. It can seem like CNS lymphoma is a common brain tumor diagnosis, but can you help put that into perspective a little bit, Dr. Chukwueke? How common is CNS lymphoma?
Thank you, Rachel. And again, I echo everything that Dr. Nayak just said. So I think it's really important to distinguish when we talk about CNS lymphoma. What we see in our group is both primary central nervous system lymphoma, and then also what we call secondary central nervous system lymphoma, which is actually much more common and sort of really forms the basis for how we evaluate any patient that comes in with suspected lymphoma. What is more rare is the primary central nervous system lymphoma. It's a small percentage of all primary brain tumors. So again, tumors which are only involving the central nervous system, not coming from anywhere else in the body. In terms of sheer numbers, again, we do tend to see a lot of this in our group, both in the clinic and the hospital. So I think it does tend to skew our sort of view in terms of how much actually the disease exists in the community. But there's roughly about 1,500 new cases of this disease of primary central nervous system lymphoma, which are diagnosed in the US. So again, a pretty small percentage of the overall number of primary brain tumors that are diagnosed each year.
Thank you. Dr. Nayak, let's dig into this a little bit more. Is it a tumor that starts in the brain, CNS lymphoma, or does it move from the body to the brain? Dr. Chukwueke mentioned, secondary, primary CNS lymphoma. Can we talk about that a little bit more?
Right. Thanks, Rachel. I'll expand a bit on what Dr. Chukwueke was talking about. So, primary central nervous system lymphoma, or primary CNS lymphoma, is a disease that is restricted to the central nervous system. And this includes the brain, spinal cord, the spinal fluid, or the subarachnoid space, as well as the eyes. However, in the absence of systemic disease. However, secondary CNS lymphoma, which Dr. Chukwueke just mentioned, is slightly more common than primary CNS lymphoma, is a tumor that comes from the systemic space, which means it can arise in lymph nodes or other organs in the body. Secondary CNS lymphoma can occur concurrently with systemic disease. That means that patients can be diagnosed with CNS as well as lymphoma in the body. Occasionally, it can occur within 6 to 12 months of the diagnosis of systemic lymphoma, and rarely it can occur by itself more than a year after the initial diagnosis of systemic lymphoma.
Something that people wonder about a lot, Dr. Nayak, are risk factors. Can you tell us, are there any risk factors for developing CNS lymphoma specifically?
So primary CNS lymphoma is considered a disease of older people. However, the median age that patients are diagnosed nowadays is about 65 years. So majority of people are over that age. In the 1980s, there was a significantly higher incidence of primary CNS lymphoma seen in younger people in their 30s and 40s, and sometimes even younger than that. And this was seen concurrently with the AIDS and HIV epidemic. And so immunosuppression was found to be a significant risk factor in developing CNS lymphomas. However, in the 1990s, when there were better treatments for AIDS and people with HIV were living longer and not developing the AIDS disease, that is when the incidence in younger people dropped again. There is still a risk in immunocompromised patients, and this involves those that have any other disorders that lead to permanent immunosuppression, some that are in childhood, and some that are inherited over time. And then others are when patients undergo transplants, such as renal transplant or liver transplant, organ transplant from other donors. They require to be on immunosuppression to maintain these organs. And so these patients can then develop CNS lymphomas as well.
Thank you for that. It's very helpful to know. Dr. Chukwueke, what are the symptoms that patients experience prior to a CNS lymphoma diagnosis?
So what I think is really quite interesting, and Dr. Nayak actually sort of in her teaching to our students and residents and fellows, one of the quotes that has been used to describe central nervous system lymphoma is the ghost disease, meaning that, the symptoms can be varied, they can be very difficult to pin down. One of the challenges, again, as we noted earlier on, is that since the central nervous system is 4 compartments, so it's the brain, the spinal cord, the eyes, and the CSF, or the leptomeningeal space. Your symptoms can really evolve or arise from involvement in any of those spaces. The more common involvement tends to be with the brain, so any aspect or region of the brain can be impacted. It can be things that can be very difficult to pin down, such as changes in personality, changes to mood, people just acting very differently. They can be more obvious and sort of symptoms that trigger more immediate evaluation, such as changes to vision or a seizure, or changes to the way someone is walking, speaking, or functioning. And then also, just to complete things in terms of involvement of the spine, some people can have changes to their bowel or bladder function. They can notice changes to sensation in their lower extremities. Or again, with involvement of the spinal fluid space, it can be other types of symptoms, again, changes to vision, changes to how someone is speaking, changes to hearing. So the symptoms can be quite varied depending on what part of the nervous system is involved. So that can make it somewhat challenging to diagnose if this is not sort of the first thing on a doctor's or on the radar of the person evaluating the patient.
Very interesting. Yeah, and indeed, really varied. You mentioned a lot of symptoms, different symptoms. Thank you.
Sure.
If a patient, let's say, does get an MRI and the lesions on the MRI are concerning for CNS lymphoma, what are next steps? Are there any other tests that you would do, and what function do the tests serve? What information do they give you?
Yeah, so at least I can walk you through what happens when a patient comes into our care here. So generally, if a patient presents with an MRI that's concerning for, after any of us review it or after we review it with the radiologist, if there is concern for CNS lymphoma, generally, if the person does not already have a history of lymphoma in the body, in which case we think that likely the diagnosis is then at that point lymphoma in the brain, we are looking to confirm the diagnosis, generally with some kind of surgery such as a biopsy. And so we would work to try to get our patient into the operating room as quickly as possible to get a biopsy to confirm disease. And what we think is also quite helpful with the tissue is that ultimately what we get from the biopsy, we think can actually influence the treatment. And I think we will discuss it later on in this webinar. But we know there's some interesting findings and changes that we can see in central nervous system lymphoma that's different from other brain tumors, which can influence how we treat the disease ultimately. So after the biopsy, our role then is to really determine if there's lymphoma involving any other part of the nervous system. So we'll, again, if we've already had the brain MRI, we'll look at the spine MRI. We will try to get a sample of the spinal fluid, and then we'll also have our eye doctors do a specific eye exam to ensure there's no evidence of lymphoma in the eyes. We also want to confirm or rule out the presence of lymphoma elsewhere in the body. And so we'll get a PET scan to look at, again, the entire body to make sure there's no evidence of lymphoma hiding out. Specifically in men, we'll get an ultrasound to look at the pelvis and the testes, as we know that lymphoma can oftentimes hide out there. So it's very important to evaluate for that, because oftentimes the PET scan may not pick up on that. Once we've confirmed where the disease was, then there's other testing that we do in preparation for treatment as well.
Wow, sounds like a very comprehensive evaluation.
It is. Yes, it is. Generally what we tell our patients is that things tend to be quite chaotic and complicated at the beginning as we're getting treatment started, as we're finalizing a treatment plan. This may often involve many members of our team, working in a very coordinated fashion, but it really is aimed at trying to get a diagnosis and to begin treatment appropriately.
Okay, so Dr. Nayak, once the diagnosis is confirmed, the workup has been done, the extent of disease is established, how is lymphoma treated typically?
So yeah, the treatment is, of course, the most important part after the diagnosis is made and we have evaluated the extent of disease. I'll just highlight one thing is that we like to get the extent of disease performed pretty quickly, occasionally within a few days, because I like to always say time is brain, and time is very crucial in this case. This is a very treatable disease, and we know that patients that have been treated within 1 month of development of symptoms, that means they were diagnosed and treated within 1 month of development of symptoms, did significantly better than those that took a longer time for diagnosis. So although I'm slightly deviating from to answer the question that you asked me, it's important to highlight that newly diagnosed primary CNS lymphoma needs to be treated pretty quickly in order to improve not just neurologic function, but survival overall. So we now know that treatment of primary CNS lymphoma for newly diagnosed PCNSL involves 2 phases. The first phase is called induction therapy, and the second phase is called consolidation. Induction treatment basically means that we're using treatment to eradicate or get rid of all possible evidence of the disease that we have available to us. And this is by looking at all of the aspects that Dr. Chukwoke just mentioned about disease on MRI, disease in CSF, disease in the eye, wherever it might be. And consolidation then basically means that we're now looking to prevent the disease from coming back or recurring. So let's first start with induction. It's now well established that high-dose methotrexate, which is a type of chemotherapy agent, is the best treatment option that we have. However, with several clinical trials and that we and others have performed, we now know that addition of other chemotherapeutic agents or immunotherapeutic agents to high-dose methotrexate improves response rates as well as survival. At our institution, we use high-dose methotrexate in combination with temozolomide, which is an oral chemotherapy drug, and rituximab, which is an immunotherapy drug. It's a monoclonal antibody that is targeted towards a protein called CD20, which is found on malignant lymphoma cells. We treat patients with at least 8 doses or 4 cycles of this treatment with MTR. And during the course of treatment, we evaluate for how patients are responding to this treatment. And once there is a response or a complete response established, we then move to consolidation. So again, the goal of consolidation is to prevent disease recurrence. In the past, historically, whole brain radiation was used as a consolidative method, and this seemed to work very effectively with high-dose methotrexate-based chemotherapy. However, what we found increasingly was that it led to a significant high incidence of what is called neurotoxicity. Patients were developing decrease in their memory, difficulty with walking, and this was found to be progressive and irreversible. And so we started looking at other alternatives to reduce the incidence of neurotoxicity. And now at the majority of institutions, including ours, we do not offer whole brain radiation as a consolidative effort unless there are other reasons for offering this treatment, such as lack of response or difficulty in tolerating the standard of care chemotherapy. What is now well established in more recent trials is that for patients that are younger than 70 years of age are benefited by treating with high-dose chemotherapy with autologous stem cell rescue. What this means is that patients that receive a response with high-dose methotrexate-based chemotherapy are deemed to be chemoresponsive. And so the premise of this autologous transplant is that we then would give additional high doses of chemotherapy with drugs such as Thiotepa that are known to penetrate the brain and also eradicate any microscopic tumor cells that may be around. And the transplant are autologous cells that are given back to the patient as a rescue. And this modality was previously studied in single-arm studies, which was found to be very beneficial, but it was unclear whether this was better than just chemotherapy alone. And so we and others have conducted clinical trials to identify whether chemotherapy by itself may be sufficient. And it was found more recently in a trial that was conducted in Europe that transplant is now the recommended treatment of choice for consolidation. However, a note should be made that this is only for patients that are considered to be eligible for transplant. And what does it mean to be eligible for transplant? Well, this is not a trivial treatment. It can only be performed and done at certain specific centers that are capable of giving transplant, because patients need to be admitted for several days and sometimes over a month even in special units so that they can be monitored very carefully while they recover from this very difficult chemotherapy period. And so people that undergo transplant need to have a very good, robust physical condition. Their organs need to be in a very good shape, and specifically the heart, the lungs, the kidneys, liver, all organs, and physically patients need to be in a good enough condition to be able to tolerate this aggressive type of chemotherapy. But those that are able to tolerate it, we certainly recommend that. And then if this is not an alternative, we offer here in our institution chemotherapy agents as well as clinical trials with immunotherapies as well as alternative novel therapies to follow after chemotherapy with high-dose methotrexate.
Wow, thank you very much for that overview. Dr. Chukwueke, are there variations of this treatment for patients that have lymphoma in the rest of their body?
Yeah, thank you, Rachel. Definitely for patients, regardless of whether it's primary central nervous system lymphoma or if we do establish that they have evidence of lymphoma elsewhere in the body, with rare exception that I'll touch upon, the backbone of treatment for involvement of lymphoma in the central nervous system is with methotrexate. So the high-dose chemotherapy that Dr. Nayak has already introduced, that has the longest track record for treating lymphoma involving the nervous system, though noting some of the things that we do need to monitor for if patients are to receive this treatment. If we do establish that there's evidence of lymphoma elsewhere in the body, a couple of questions do come into play. And this is where, again, we talk about sort of involving the multidisciplinary team. If this is someone who we're also establishing a new diagnosis of lymphoma in the body, we will consult with the systemic lymphoma team or the body lymphoma team, who will do additional testing and decide what that chemotherapy regimen may be. Generally, this could be determined based upon the patient's age or other risk factors, which, may establish if this lymphoma may be more aggressive or more standardly behaving. So generally, we do work quite closely with the body lymphoma team, as ultimately, if there is evidence of disease outside of the brain, we'll have to coordinate the patient receiving both the methotrexate and ultimately what that additional chemotherapy may be.
Thank you. Dr. Nayak, you mentioned admission during treatment. Can we get into that a little bit more? Why does the treatment need to be given inpatient?
So high-dose methotrexate, which is the backbone of the chemotherapy regimen for primary CNS lymphoma, needs to be given inpatient. The rationale for this is that this is by its name given in high doses. And when it's given in high doses, it's also delivered at a very fast rate. And this is done so that it can get into the brain. The same dose given over a longer period does not get into the brain parenchyma and the spinal fluid into the same concentrations. What happens is that you can imagine a high level of the drug then is also in the peripheral circulation, which is blood. And from there, it can go on to affect other organs. We want it to kill the cancer cells, but we want to protect other organs at the same time. The more important organ that can get affected are the kidneys, because methotrexate is cleared or removed from the body by way of kidneys. And in the kidneys, it can form crystals and damage the kidneys. In order to prevent this from happening, patients need to receive intravenous fluids, meaning fluids through the veins, constantly. And roughly it's about, as I say, it's a can of soda every hour. And this needs to happen for about 3 to 5 days until the methotrexate is completely cleared. And so for this reason, as you can imagine, it's quite hard for people to be able to drink so much of water or alkaline water for constantly 24/7. And so it requires patients to be admitted into the hospital. One thing is that some patients can be quite sick in the beginning, and before they recover their neurologic function, it may be better for them to be in the hospital, to be monitored as well. So it works quite well to be treated as well as to give the chemotherapy. On that note, though, I do want to mention that we have participated in a trial that is now looking to be seeing if methotrexate can indeed be given as outpatient, because this will be tremendous for patients in terms of quality of life and also in terms of reducing hospital stay. But more to come on that in the future years.
Oh, wow, that's exciting. I actually hadn't heard of that. Yeah, helpful for a lot of our patients. You talked about, the important role of the kidneys in clearing the drug. So what are some complications if that process of getting the drug out of the body doesn't go the way it's supposed to? Are there any treatments that help with that, with those issues?
Right. So there is a drug called leucovorin, which is given to prevent damage to all other organs at the same time. And as I mentioned, we give intravenous fluids, which are alkaline. So this keeps the pH of the blood and the urine high enough so that the methotrexate can be assisted in clearance. I want to mention just briefly in cases where the methotrexate levels get very high too fast, and the kidneys that may already be partially damaged from other causes like vascular diseases or diabetes, which some of our patients may also concurrently have, we use a drug now called glucocorticoids. It's important to know that glucocorticoids wasn't available before 2012. And this helps with actually clearance of methotrexate. It's an enzyme which cleaves the methotrexate that then allows it to be cleared pretty quickly. And that was the same drug that I was referring to. We were trying to use this to see if we can use it as an outpatient as well, more recently. But before that, we would just have to wait it out if patients were undergoing kidney damage. There was a question that just came up, which is sort of, I think, relevant to what we were just talking about in terms of how different, so I'm going to read the question out, how different are the milligram pills for Sjögren's or arthritis compared to the hospital stay for methotrexate? And this is not in the same dose. We cannot give methotrexate in pills forms. This would actually need to be given as intravenous drug. The dose that we use is 3.5 grams per meter square or 8 grams per meter square. We use that alternatively depending on age, kidney function, and other factors and other involvement of different parts of the nervous system. But those are sort of the standard doses of high-dose methotrexate that are used. And these doses are significantly higher than the pill forms that are given for arthritis or other autoimmune or inflammatory conditions that don't need kidney monitoring as is required in this case.
Interesting. Thank you for picking up on that question. I actually do want to just remind the audience as well to enter any questions you have in the Q&A. I know sometimes, you know, the webinar gets going and you can forget that there's going to be a full Q&A at the end of our scheduled programming. So please do feel free to enter your questions, and we'll answer them too if, you know, something is relevant beforehand. So thank you. Dr. Chukwueke, how many methotrexate treatments do patients usually receive?
And so this is, again, varies on a number of factors. I would say in general, in our practice, among the patients who are treated here, we tend to shoot for 6 to 8 doses of methotrexate or 3 to 4 cycles. Again, let me step back. This is generally for primary central nervous system lymphoma that I'm speaking about. Our practice is to follow up with the patients in terms of imaging every 2 months, every 2 doses or once every 4 weeks. So generally after the first 2 doses of methotrexate, we'll plan to have an MRI to really see what the initial response to methotrexate is. And usually what we tell patients and their families are that even after, again, we shoot to see no more evidence of disease on the scan. So even after we achieve that on the MRI, we do generally will still treat with another couple of doses to methotrexate to make sure that the disease is continuing to respond and we're not seeing any recurrence over the short term. So I would say in general, most patients who are responding to methotrexate receive about 6 to 8 doses of the treatment.
Okay, great. Thank you. Dr. Nayak, you also mentioned rituximab and temozolomide. What are these medications and how are these medications given?
So rituximab, I think I just mentioned it's an antibody and not a traditional chemotherapy. It's given through the vein. It's found to be extremely important in treating systemic lymphoma, an integral part of treatment of systemic lymphoma. The majority of data suggests that it's helpful in primary CNS lymphoma. However, we have seen conflicting data regarding that effort. We do recommend rituximab unless it's contraindicated, though. With temodar or temozolomide is an oral chemotherapy. It's what is called an alkylating agent. It's a traditional type of chemotherapy that we know is effective in brain tumors. It penetrates the brain. And in combination with rituximab was initially studied in the context of relapsed and refractory primary CNS lymphoma, found to be quite effective, and then was moved into the upfront setting several years ago. Now I think almost 2 decades ago. And so we use this combination regimen.
Great. Okay. You mentioned sometimes rituximab is contraindicated. Can you just talk about that a little bit more for those on the call?
So there are a few contraindications to rituximab. I mean, one of the more common ones is those that have an allergic reaction to this, because it's an antibody and patients can develop an allergic reaction. It's a hypersensitivity or an acute hypersensitivity reaction. So allergies occur during the duration of infusion or soon after, rather than a prolonged drug reaction that you could see with other drugs. And in these cases, if we do wish to continue giving rituximab, we would have to work with the allergist to do desensitization, and if that may or may not be feasible based on the recommendations of the allergist. And then this is not an absolute contraindication, but there are certain immunocompromised states that may make it a bit harder for us to use rituximab. And so we'd use that with caution. I generally hesitate to not using it, at least in the first line setting, but in the relapsed refractory setting, these are cases when we might consider not using it.
Thank you for clarifying. Dr. Chukwueke, you mentioned MRI scans to evaluate if the treatment is working. I think you said you do the first scan after 2 methotrexate treatments. How do we know if the treatment is working?
Yeah, and we really rely heavily upon the imaging. Obviously, we treat you, the person, not just the imaging, but we know that central nervous system lymphoma is one of the few brain tumors where we can expect to see it, shrink and disappear on the MRIs. And that really gives us the indication of how well the treatment is working. We think that most people do respond to methotrexate. Probably, up to 70% of people have a response to methotrexate. What we are looking for, however, is what we call a CR, a complete radiographic response to the chemotherapy. And so, with the imaging, that is how we best monitor for whether or not the methotrexate is working still, or if we need to pivot to another treatment plan altogether.
So what percentage of patients are able to completely clear their disease, have a complete response with the treatment that you both described?
Yeah, so I think the numbers that we tend to deal with is about 50% who clear entirely on the scan. And let me also indicate for people that also have disease elsewhere in the nervous system. So I think we're focused a lot on the brain. We know that there can also be instances where people have brain and involvement of another compartment, such as the eye, or individual involvements of different compartments. So for those people who do have documentation of lymphoma involving the eye, we have them in parallel with the MRIs of the brain to also have periodic eye exams with our retina ophthalmologist. And again, they'll do this special test called the slit lamp exam to monitor for the presence or resolution of lymphoma cells in the eye. And again, for people who have involvement, for example, of the spinal fluid, we will also sample the spinal fluid with lumbar punctures to make sure that we're seeing appropriate clearance of disease with the treatment. So for most patients, it is a brain MRI. And then in those other instances where we know there's involvement of other compartments, we will do those additional tests, whether an eye exam or spinal fluid assessment.
Right, okay, so for those patients that, maybe had workup at the beginning and those assessments show disease in different areas, you would continue to do those assessments to evaluate the disease.
Exactly, because we don't want to miss disease that we should have been following from the beginning.
I just want to quickly mention, we had a question for clarification here. This is regarding, I believe, about complete response. Did I hear only 15 or is it 50?
It's 50,
Okay, thank you.
50%, yeah.
50%, okay,
Thank
great.
you for asking that, yes.
So in the case that disease does completely clear, and there's no evidence of disease in the MRIs or any other applicable assessments, is a patient cured? Is it considered, like the patient is cured, or is the lymphoma expected to come back? Can we talk about that a little bit?
Yeah, so I'm very conservative. I never use the word cure. I don't think that word ever comes out of my mouth, not because I don't agree that it can happen. I just want to make sure that we're setting the correct expectations. So, in the instances where one has completed treatment, they've gone through induction or consolidation, we see that there's no evidence of disease. We still enter, follow a period of active surveillance. And that's generally, it's very, it's stated in what we call the NCCN guidelines. So this organization sets guidelines for how we monitor cancer over time. And so there's a set of guidelines for which we follow patients, whether it's every few months for a couple of years until generally we get to the 5-year mark. And then again, we will reassess what the need for follow-up is at that point. Again, I stay away from using the word cure. I tend to say, we can, hopefully we push for a period where we don't have any evidence of disease, or it does look like the disease is under control with the treatments that one has had. But certainly as compared to some of the other brain tumors that Dr. Nayak and that I treat as well, we do have high expectations for disease control in this situation.
Great, okay, thank you. Dr. Nayak, let's say, a patient gets this treatment that we all discussed, and, they don't have any evidence of disease and they enter this period of surveillance, if you will. Do you have any kind of general sense, or what do you tell patients when they ask, if it comes back, how soon is it coming back? Or, are there treatments that people would go on to prevent recurrence?
Yeah, very good question. So we'll first talk about how soon can it come back. So the highest risk of recurrence is in the first 2 years. And most patients that do recur even after an auto transplant recur in the first year, based on the clinical trials. After that, the risk reduces. So about 50 to 60% of patients do recur within the first couple of years. And so, as you can imagine, we're really trying to improve not just treatments at recurrence, but also our upfront treatments to increase this interval between the next recurrence, if you may. So the next is landmark, as Dr. Chikwueze just mentioned, based on the NCCN guidelines for monitoring, is 5 years and then 10 years. But, in the course of my experience, and also based on some of the publications that I led, we did note what are called late relapses. So you asked about cure in most cancers, and particularly in systemic lymphoma, patients that don't recur within 5 years are thought to never recur again, or the risk of recurrence is very low. However, we did notice that people would, in fact, recur even after 5 years of treatment. And so late relapses can occur, certainly. What are the treatment options at recurrence? Well, I would say I follow the NCCN guidelines, which recommend, I'm at Dana-Farber, so we always recommend a clinical trial if possible. And the reason why we recommend a clinical trial is because there are no standard of care guidelines after the initial treatment. So it's unclear whether one treatment is going to be better than another one at first relapse or at second relapse or after that. What we do use in the absence of clinical trials is our best judgment based on how patients have done over the course of their initial disease. So what are the factors? The factors would be age, performance status, which means how well the person feels physically. What is their organ function? What can they tolerate? What is their neurologic function? How much of dexamethasone dose do they need? Because this can sometimes interfere with some newer treatments like immunotherapy or, also CAR T-cell therapy. It can increase the risk of infections with some of our newer therapies. So these are some of the factors that go into deciding. And what kind of response did they have with chemotherapy to begin with? And for how long was their response maintained? Did the disease recur within 6 months of completing the therapy? Or did their disease recur after 5 years of completing the therapy? So as you can imagine, this is a rare cancer, so treatments are quite nuanced. We offer several clinical trials. And again, like I said, in the absence of clinical trials, we combine either chemotherapy or other novel agents that are available and offer them to patients. And then finally, I always like to mention that, most of my patients will hear me say that I don't necessarily recommend radiation or whole brain radiation, but I will use it. And we do use it and recommend using it in certain cases where we feel that the tumor is progressing too rapidly, or we feel that maybe some of the treatments that we employ may not work as quickly, or if they're not working as well. Because at the end of the day, it's important to not just preserve life, but also neurologic function, which can be permanently impaired if we don't act quickly enough.
Thank you. Very helpful to know. Sounds like it can vary a lot, patient to patient, based on a whole bunch of different factors. So somebody asked this, I'm wondering if, I don't know if you know off the top of your head, but somebody asked this over email. What is the longest that you have seen somebody go after initial treatment before recurring?
You want to take this one, Dr. Nayak?
Over 10 years. I think the first patient that I'd seen that led to our first paper of late relapses was 13 years later. And we wondered if it was the same disease or a different clone. And we were quite confident that when we analyzed pathology, that we were going to find that this was a new disease and it was the same clone. So I would say that, but I want to mention that the longer patients are disease-free, the lower the risk of recurrence is. So, we talk about surveillance or the fact that disease can recur later on, not to scare people, but really to make sure that we are able to follow in the best possible way, which means that insurance would then reimburse for MRIs that are performed further out. Because again, the brain is is something that we could, we depend a lot on, of course, on all of our organs, and of course, I'm biased, and we're biased in the Center for Neuro-Oncology, but brain cancers have a different impact on people's lives, and so it would be very important to be able to diagnose a recurring disease before people were symptomatic, whether it was 10 years out or not. Again, I really want to highlight that people that recur after 5 years, it's very, very uncommon. It's almost doesn't happen. The risk of recurrence after that is very low.
We have someone actually in the audience, an anonymous attendee, that is 10 years out from their initial diagnosis and treatment. So that's very exciting. Thanks for sharing. Before we come to a close here, I'm hoping we can talk a little bit about clinical trials, because that's, one of the things that both of you do a lot of for CNS lymphoma in particular too. Maybe each of you can tell us a little bit more about your research areas.
I'll just start very quickly and then have Dr. Chukwueke follow. So we have trials based on the work that we've been doing. And the work that we've been doing is preclinically. So we look at tumor tissue, we look at spinal fluid, and we also are trying to see how the disease actually does go into the brain and interacts with the brain. And so we have identified, and so have others, some specific mutations and abnormalities that are very unique to primary CNS lymphoma, that then led to its identification as a very distinct disease compared to lymphoma elsewhere in the body. And that led to a lot of clinical trials. Some of our clinical trials are involved in the upfront setting, where we would offer chemotherapy as well as novel agents. And the majority of our clinical trials are at recurrence, and I'll let Dr. Chukwueke talk about the trials and the specific drugs that we're working on.
Thank you, Dr. Nayak. So, as Dr. Nayak mentioned, there are a few trials that we're working on in various stages. One trial that really did evolve from some of those unique changes that we found in primary CNS lymphoma is a trial using a regimen of 3 medications. So one is a medication called pembrolizumab, which is an immunotherapy drug. It's gotten a lot of buzz for treatment of other cancers as well. Pembrolizumab in our study is given in combination with a medication called ibrutinib. So it's part of a class of drugs called a BTK inhibitor. And then the third drug is a drug we've already mentioned in the webinar earlier on, a drug called rituximab. So in addition to that trial, there's 2 other trials in which we're looking at 2 other BTK inhibitors. So another is a study of a drug called acalabrutinib, so very similar to ibrutinib in that first study. And then another drug called tirabrutinib, for which there's been a lot of interest in over the last few months because of some of the early results from that study, which were presented at our big oncology meeting earlier this year. And I think one other thing that's worth mentioning, as we talk about this being a very rare disease, so as this is a rare disease, Dr. Nayak and I are very much in a position, because of the volume of patients that we see, to really try to better understand some of the patterns and outcomes in this disease specifically. So we're also looking at a very rare type of, even rarer than central nervous system lymphoma, a rare type called a T-cell lymphoma, which is exceedingly rare. We probably see about 1 to 2 cases a year, which is more than any other center probably in the world. So we do have a cohort of patients who we're following and getting information as far as how they did with treatment, what were some of the unique features on their biopsy, what specific treatments they received. And then we're also taking a closer look at how our patients did in general, depending on what they received for consolidation. So whether they received stem cell or rescue, or whether they received other chemotherapies, again, really looking towards how can we improve treatments for people with this very rare disease, and improving both survival, but more importantly, maintaining neurologic function.
Very exciting work that you two are doing. Thank you for doing the work for all of our patients, but also for, explaining it so comprehensively. We're going to end today with the formal questioning, but I wanted to just ask the two of you if you had any takeaway points that you'd like to leave for our audience.
I'm a big proponent of, and I think all of you who joined the webinar are similar, a big proponent of, really taking control of your care. If something doesn't seem right, if you're concerned about, what's happening, or a concern with your family member, make sure that you do speak up. This is a very challenging disease. And as Dr. Nayak already said, we think the impact of disease with brain tumor patients is very different. And this has been studied, is very different compared to other cancers. So definitely be an advocate for yourself as well as your loved ones.
Yeah, and I'll go further and say that because it's a rare disease, it receives less focus. So it's very important for patients and families to be the voice to make the change in, what kind of resources and research we can do now and in the future. I know many of you are involved in many different ways in outreach, as well as dedicating time and resources to our work. But, your voice is extremely important, always, and will really get us to treating brain cancers and, going from where we are right now to very, very treatable and curable.
Thank you both so much. I second what you're saying. We really want to hear from you too about the development of this program and the future webinars, and your perspective is valued in advancing, what we have to offer here in all areas. So Dr. Nayak and Dr. Chukwueke, thank you again so much for such an engaging discussion on CNS lymphoma. People who are attending today, I just wanted to say, please do answer the poll if you can, that's going to pop up at the end of today's webinar. And I also just wanted to add a few things. One, our next webinar is going to be on October 25th. Dr. Callum Lee and Dr. Lisa Akalanti will be discussing the diagnosis and treatment of brain metastases. And we also have a new exciting program to announce that will be happening later this month, actually, with the director of the NOW program, Dr. Gonzalez Castro. This will be an exercise for neuro-oncology patients webinar course. So this is going to be a 3-part series. We are sending out more information. So if you already get our emails for the NOW program, you should be receiving one shortly about this exciting new opportunity later this month. However, if you would like to sign up for notifications and you aren't currently receiving them, I will be pasting a short survey in the chat that you can fill out to stay up to date on our events. And then the other thing I wanted to say is that there is the American Brain Tumor Association symposium that's happening later this month. And I'm going to put that link as well because you can attend virtually for free. If you are, I think it's in Chicago. Is that right, Dr. Chukwueke? If you are in Chicago, I believe attendance is free in person as well. But for those of you who aren't, it is really going to be a wonderful event. And Dr. Chukwueke herself, I know, will be there. So I'll put that in the chat as well. Thank everyone, Dr. Chukwueke, Dr. Nayak, and everybody who attended today. This was a great webinar, so take care.
Thank you. Bye-bye.